Okay, so my beard got longer since then, and I got older. Thank you. And as indicated before, these are the other two co-founders of the CyberMed Summit there in San Diego today. The good news is the success we've had both got them a cyber center that they're pioneering at UCSD in San Diego. And on top of that, ARPA-H, which is not the original ARPA, but the healthcare new grant programs out of HHS, has awarded them and their university an ARPA-H grant to try to make hospitals more resilient and recover more quickly in the face of ransom disruptions. So we're really proud of what they've started here with us and what they're doing in parallel. Okay, so let's jump in. I need to time myself. I'm going to give you too many slides and too many pictures. There will not be a quiz. It will be recorded, but we're trying to make sure we realize that we're solving for the right scope and the right entanglement, because healthcare does not exist in an island, cybersecurity does not exist in an island. And for a little bit of context, prior to starting CyberMed Summit, almost 11 years ago on August 1st, I started a group called IamTheCavalry.org, a nonprofit focused on where bits and bytes meet flesh and blood. The idea here, I should probably say who I am. I'm Josh, by the way, I should have said that earlier. Josh Corman. I'm a philosopher by training who ended up in the hacker community and was professionally a chief information security officer, chief security officer type things, and I teach those. But increasingly over time, I was deeply worried that our dependence on connected technology was growing a lot faster than our ability to secure it. And if we couldn't protect credit cards, why were we putting the same things we couldn't defend into medical devices, cars, industrial control systems? At some point, I was researching the rise of anonymous and activism, and the intelligence community said, how do you guys keep getting everything right? You guys keep predicting what's going to happen. And we built a lot of trust, and there's a longer story, but because I have so many slides, I'm going to give you the truncated version. We spent 2 days at Fort Meade with Jen Alexander and Ian Newberger, and 5 of his hand-picked best people, and 5 of my best picked helpful hackers, and we tried to answer challenge questions, and we came up with breathtaking ideas about how to better protect national security, public safety, human life. And at the end of it, he couldn't implement a single suggestion, not even one. And it's not because he's a bad guy. He's like, I don't have the authority for this. There's no political will for this. Until people start dying, there's not going to be any support for this one. And a lot of us went back to the airport to fly back home, and nobody really spoke for a good long time at the bar. And I finally broke the silence and said, guys, the cavalry isn't coming. No one's going to save us. What I didn't tell them is that my mother's initial stroke, I had found out earlier that day that it was actually the front wave of pretty aggressive terminal glioblastoma. And we knew that we were going to lose her. So I was kind of dying inside on a personal level, and my sisters and I ended up hospicing my mother for the next few months. And during her funeral, I said something to the effect of, that's a longer story. But basically, during her eulogy, something clicked in my head that if something's missing in the world, maybe it falls to us to put it there. So the solution to the idea of the cavalry isn't coming is not to like wring your hands or mope or dread the sky falling. So I went to the hacker convention later that year, and I said, hey guys, if the cavalry isn't coming, what are we really able to do? So this was not Josh, this was not Bo. This was a personal declaration we wanted each of you to make. And to our delight and surprise, it wasn't just hackers, it wasn't just patients. It started to become lawyers and policymakers and medical device makers and people in automotive. And we went from maybe 50 people to maybe 150 people to a couple thousand people. And we're just idiot altruists trying to do what we can using empathy to meet people where they are, identify and buy down risk, and try to make the world safer sooner together. So just by virtue of you being here, I'm hoping that you're one of those kindred spirits. Okay, so I want you to look up for a minute. How many of you sat in perpetual fear that this building was going to collapse upon you and crush you? Anybody? We always get one or two. This building's made of steel and concrete. Steel and concrete are infrastructure. They are dependable infrastructure, and we depend upon them. They are so transparent to you, you didn't even think about it. If you came through a tunnel, if you drove over a bridge, nobody worried about it. And even before the cavalry, we had this concept called rugged software. We said, we are becoming as dependent on software as we are on steel and concrete, and we're putting it everywhere. But unlike steel and concrete, it's not nearly as dependable. In fact, it's infinitely vulnerable. And we thought that was a big deal. We want to get to the point, we trust software, we trust connectivity, we trust it everywhere. It's all over this room, it's all over your hospital, it's in your car, you can't get away from it. Problem is that trust is not well placed, and we're seeing that we are over-dependent on undependable things. So that has been the thrust of the cavalry. It's the relationship and the mismatch between over-dependence on undependable things has exposed us to accidents and adversaries, where even the smallest outlier can have a profound impact on public safety, economic, national security. And increasingly, the US and allied governments have caught on to this. It's unfortunate that we had to have harm before they would start to pay attention, but we have done the patiently impatient work to try to get us there. So that's the through line as to why we started out the cavalry, and ultimately why we started CyberMed Summit, to go much more acutely at healthcare, which is 20% of GDP, but every single one of us needs healthcare from when we're brought into the world until we leave it. And you don't usually think about it until you need it, but when you need it and you can't get it, delayed, degraded care affects patient outcomes and even loss of life. So we've all heard of Maslow's hierarchy of needs. He actually never wrote it as a pyramid. That was a reinterpretation of his original writings. But the notion here is, no matter how sophisticated you are or your society is, we are Lord of the Flies if we have fear or instability at the bottom. You can only operate the layer of the pyramid that you feel most secure. So you're not going to be writing poetry or sonnets or Broadway plays or creating iPhones if you want or fear for food, shelter, safety. And unfortunately, as we added software connectivity and exposed ourselves to accidents and adversaries, we have increasingly allowed anyone to reach out and touch someone and disrupt those basic human needs. So for example, while I was at CISA, helping to design and implement the CISA COVID task force for the pandemic response for hospitals, vaccine supply chains, we saw successful electronic disruption of the water you drink, the food you put on your table, oil and gas pipelines for the eastern seaboard that fuel your cars, your homes, your supply chains, the schools your children attend, higher ed, the municipalities who run towns and cities, and even timely access to patient care with proven moral consequences. These aren't HIPAA violations. This is delayed, degraded care for not hours or days, but for weeks or months. And you can use statistical evidence to quantify minimum, maximum, most likely death for otherwise preventable conditions through excess death analysis. So in the before times, we were trying to raise the alarm without being alarmist. And part of that empathy was to talk to doctors and physicians and read medical journals. And one of the most profound ones at the time, as we were doing the Congressional Task Force on Healthcare Industry Cybersecurity, in the New England Journal of Medicine, this was not a cyber report, but somebody studied US marathons and heart conditions. And they found that if you had a heart attack in a US marathon city during the hoo-ha, you had a statistically significant elevated 30-day mortality rate. And the key linchpin was the 4.4 minutes longer in your ambulance ride to get around the route. Had a measurable, statistically significant elevated mortality rate. Well, what does that have to do with cyber? Pretty much nothing, but what was profound for us as we compared notes is delayed, degraded care, irrespective of cause, can affect outcomes for time-sensitive, latency-sensitive conditions. Sorry, I keep neglecting the cyber. So we took that in and we said, okay, I'm pretty sure a ransom event can introduce a 4.4 minute delay. So with heart, 4.4 minutes can have a measurable effect. With strokes, time is brain. The golden hours, 1, 3, 4 hours could be the difference if you walk again or talk again. So if 4.4 minutes can affect mortality rates for heart, and 4 hours could affect mortality rates for stroke, what could 4 weeks do in the state of Vermont when hit by a ransom attack? So we're going to hear a little bit more about that, and you'll see how my remarks will tee up other speakers. Okay, so we did a congressional task force called 405C, asked for in CISA 2015, a law that has a different acronym than the agency. And the headline of that report, which we're not going to review because some of you see this every single year, is we said healthcare industry cybersecurity is in critical condition. The report had a ton of imperatives and recommendations. But to simplify this for news readers or for my neighbors, we said there's 5 key deficits. I'm really sad to report that the healthcare sector working group on cyber came out with their 5-year strategy in January or February, and their goal is that 5 years from now, we want to go from critical condition to stable condition. 2017, we had 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29. We are not making a lot of progress. It's not that people aren't trying, but if we said to Congress in 2017 that we're in critical condition and our goal is to get stable by 2029, I have to ask, are we doing the best we can? Is there anything we can do to go faster? And I'm pleased that people from the White House, from HHS, from Congress, from CISA are all here today to speak to you, to listen, to talk to you. But it's not going fast enough. We are doing things, but it's getting worse faster. At the time, I said something sacrilegious. I said, hey, maybe we shouldn't be connecting hospitals everywhere. If you can't afford to connect it, you can't afford to protect it. Maybe we should consider proportional connectivity to our ability to responsibly operate that. Maybe not everything everywhere. You know, there's a cost to connectivity. Are we willing to pay that cost, or are we going to pay in a different way? They didn't like that very much. They got kind of mad, in fact, and I can see why. We want to use empathy. But what they said mostly is, unless people start dying, we're not going to spend a penny on cybersecurity. Like, we barely do the minimum for the HIPAA rule, for the privacy. We're not spending a penny. If you give us another $1 million, another $5 million, we would get more ambulances, more equipment, more nurses. We're not spending on cyber until people start dying. Well, part of the impetus of the CyberMed Summit was, okay, we're hackers, let's start killing people. So we did. We started killing people in ER hacking simulations. So just like pilots do flight simulators all the time, and firemen do fire drills all the time, physicians do ER simulations all the time. And we wanted to inject cyber into that. Now, we did a lot of these things before the pandemic, but the pandemic took all those stress fractures and stress points and shattered things. So I did not make this poster, my friend Ben did, but when the pandemic was declared, the newest federal agency went to Congress, and so did others, and they got emergency hiring authorities called the CARES Act under a bunch of other provisions. I got asked, will you come design and implement what became the CISA COVID Task Force? CISA stands for the Cybersecurity and Infrastructure Security Agency. And we had two goals. One was to identify and buy down risk in an Operation Warp Speed race for a cure, or diagnostics, therapeutics, vaccines. And the other was to protect the nation's 7,000 hospitals from a wide array of accidents and adversaries. Now, when the pandemic declared, everyone said no one's going to ransom hospitals. Who would do that during a pandemic? No one's that evil. Don't they need healthcare too? And unfortunately, as predicted, they preyed upon our weakness. They knew we'd pay, and ransomware's top target was, in fact, healthcare. So I'm not going to do all of these, but one of the reasons I'm going to mention this in broad brushstrokes is we had 7 or 9 Operation Warp Speed candidates for a vaccine. They had 23 suppliers that we identified that we had to protect. But then I got handed a list on my first day of 1,000 suppliers that were tiny. They said, we don't know which one of these are important. And CISA, the nation's risk management center, the nation's risk management agency, use their cyber skills, their risk management skills to prioritize these 1,000 things. We actually turned it into 4,000 with Dr. Ruben Pasternak and Michelle Holko, infectious disease expert. And within about 10 days, we had come up with a methodology of dependence and criticality and scarcity, and we turned those into 66 ball bearings. The idea from World War II is don't bomb the Germans' manufacturing of jeeps or tanks or submarines, bomb the ball bearings factories. Every warfighting device needs those. So what are those weak, unguarded links in the supply chain where a single failure has an outsized cascading effect? And this turns out, you're going to hear about later when we talk about SICI, or Change Healthcare rather, but we have these critical dependencies in each sector, and the methodology we used under the duress of the pandemic is being asked to be used now in healthcare to identify those handful of weak, unguarded points in the ecosystem where, if disrupted, have a cascading effect on everyone else. So that helped us on the vaccine supply chain. I'm going to quickly put some love language to clinicians here. Again, they don't want to do cybersecurity, and they kept beating into my head, we don't care about cyber, we don't care about cyber, we care about the 3 S's. Space, supplies, and staff. And maybe I'm using these terms incorrectly. I'm looking at one of our speakers to make sure I got these right. But generally speaking, this is a Wardley map methodology, but we said, okay, HHS wants to keep people alive, citizens want to keep people alive, health delivery organizations want to keep people alive. Well, how do you do that? You need carrying capacity geographically. Well, what is carrying capacity? Is that because we have 100 beds, physical beds? Well, that's your space. We don't have 100 beds of capacity if you only have 80 staff beds, right? It's a constraint. And you don't actually have 80 beds if you only have supplies for 60 of those 80 staff beds. So they want to talk the 3 S's, and cyber doesn't start with an S. So we didn't have very much luck. Now during the pandemic though, we started to see a whole lot of excess deaths. At the 1-year mark of the pandemic, in addition to the 500,000 dead Americans from COVID, who were mostly 80 years old or older, mostly with 4 or more comorbidities, my team noticed, hey, CDC tracks this thing called excess deaths, which is the difference between expected deaths and actual deaths, by condition, by state, by month. And I said, I'll bet you they're time-sensitive ones. I'll bet you they're heart, brain, and pulmonary. You know, we learned about strokes, we learned about New England Journal of Medicine article, and sure enough, they were. So I started to say, let's not just look at having capacity to keep people alive. Are we prioritizing? Where minutes, hours, or days are the difference between life and death. And when we looked at those excess deaths, unlike the COVID deaths, the fastest growing demographic were 24 to 44-year-olds. These were young people. And right up top on the list were time sensitive, where they were preventable loss of life, but for delayed and degraded access to care. So they were heart, they were brain, they were pulmonary, they were diabetes. So we tried to enrich and enhance that model. And the second thing I noticed is that medical technology is awesome, right? Every time we come up with a new medical technology, it is a force multiplier of staff. We talked to nurses from 1990 who worked in the natal intensive care unit, right? And sometimes it's a 1-to-1, one nurse, one patient. Armed with modern technology, we can force multiply that. You have a bunch of sensors and a bunch of telemetry and paging systems and remote monitoring stations. So now we can increase one nurse to plural patients. So if that medical technology is a force multiplier, then the unavailability of that technology is a force divider. And we have circa 2024 census and nurse to patient ratios or doctor to patient ratios, but we have actual 1990 level technology assist. And it's that overdependence on undependable things that is exposing us to accidents and adversaries that has degraded, delayed, and denied care. And that's basically what happened in the court case that's trying to settle. That was revealed on October 1st, 2021, in the front page of the Wall Street Journal. There was a ransom attack in Alabama that disrupted many systems throughout the hospital. A baby was admitted for delivery. A mother was admitted for delivery. They had a complex birth. They did not have imaging, so had not noticed the umbilical cord, which could have indicated maybe a C-section. They did successfully deliver the baby and take the baby to the NICU, but also without remote technology and monitoring and stations, the quality of care was worsened. And while the baby did get home, subsequently perished. And in the ongoing lawsuit, conversations between medical staff at the hospital revealed that they felt that the technology had not failed them. They never would have lost the baby. They could have made different census decisions. They just decided to settle out of court, but apparently that's been reversed now. So this is ongoing and being watched by policymakers, and liability as a case example. But this was a named victim on October 1st of 2021, revealed to the public. So the issue here is we're surrounded by dozens of technologies that are really useful when they work. And when they are unavailable to us, it's the patient that suffers, and it's the staff that suffers. Now, on the same day, our team at CISA published a seminal piece of research to have the first statistical proof of loss of life. It was called Provide Medical Care is in Critical Condition. That term, Provide Medical Care, is one of the 55 national critical functions that CISA tracks. And the idea of provide medical care is, can you get timely access to care when and where you need it? So it's a time and space access problem. This is an all hazards problem, and Mark Jarrett's going to talk about all hazards. It's not just a cyber attack that can disrupt provide medical care. There's all sorts of weaknesses and risks that can. But we did qualitative and quantitative analysis. And we were able to use some data science to show that on those excess deaths that I told you about, our team said, is there a leading indicator? Is there any strong positive correlation? And what we found was an otherwise not very meaningful indicator of ICU bed utilization had strong positive correlation with excess deaths 2, 4, and 6 weeks later. So when the nation hit 75% ICU strain, which is often considered optimal, depending on your city, you saw 18,000 dead Americans 2 weeks later from preventable time-sensitive conditions. If you hit 80, if you hit 100%, so if 75%, you saw 18,000 dead Americans. Again, primarily 24 to 44-year-olds. If you hit 100%, you saw 80,000 dead Americans 2 weeks later. And we hit those stress levels 3 times in the first year of the pandemic, and then we kept tracking. So we had an idea that you should manage the elective strain on your ICU with the corresponding excess deaths. Armed with that, we looked at states hit hardest by ransomware, in the same state with the same pandemic conditions and the same population, adjusting for hospital type and size, we could see that ransom communities achieved these stress levels sooner and stayed there longer than their peer groups. So allowing us to estimate minimum, maximum, most likely loss of life by type, by cause. And then in this diagram, there's a few ways you can show potential for loss of life. Number 1 is the ransom, which causes the unavailability of care. Number 2 is if you hear the term, you almost always hear the term, patient care has not been affected. It's like programmatic and robotic. But usually what follows that lately with ransoms is, we have diverted ambulances to the next nearest facilities. Well, the act of diverting them, if the next proximal care is more than 4.4 minutes away, you might in aggregate see elevated heart loss. And if they're more than an hour or 3 hours away, you might see elevated stroke loss or brain. So you have a time-space access to proximal care concern, but the real numbers started kicking up when you could look at the ICU strain at or above 100% from the overflow, and then correlated excess deaths 2, 4, 6 weeks later. Now that's older news, so I'm going to go faster now, and I do not expect you to take pictures of all these. I do not expect you to have a quiz on all these. These are 16 parts of the US government for the 16 critical infrastructure sectors. One of them, the one with the little red bubble, is HHS, which is responsible for healthcare and public health, HPH. The stuff above is before CISA was born. Each sector would manage risk at the sector level, and they would do their best with whatever biases they had, and it wasn't usually cyber. One of the things CISA was born to do was to be a shared muscle across all 16, where they could hire thousands of cybersecurity professionals, risk management people, threat hunters, incident responders, and share those across all 16. So it's supposed to be a shared responsibility. And one of the innovations they made is that instead of managing risk at the healthcare sector, where you have mortuaries, medical device makers, yoga clinics, hospitals, pharmaceutical companies, there are these 55 things that you're going to hear from Kirsten Todd later that are called national critical functions. One of those is called provide medical care. It's ostensibly chaperoned by healthcare and public health, which has a public-private partnership between HHS, the Sector Risk Management Agency, and the Sector Coordinating Council, represented today here by Mark Jarrett. In that, it's a mess because you can't just provide medical care in an island, because the ability to provide medical care depends on other national critical functions that are owned and operated by other parts of the government. So the silo alone is insufficient to manage cross-sector life safety risk. So you're not going to study these, but one of them is you need to have water. And the Environmental Protection Agency is responsible for water. You need transportation of patients and goods. You need chemicals from the chemical sector, SRMA. So these are these complex molecules, dependencies. So let's put this in Maslow's again, because none of you want to look at national critical functions and sector leadership. But at the bottom of Maslow's, when everything's critical, nothing's critical. And the Apple iTunes App Store that has Angry Birds on it is technically, you could argue, critical infrastructure because it's part of IT. But I think it's much more important that we have the ability to have drinking water, electricity, timely access to patient care. So we suggested, let's not manage risk at the sector level, let's manage risk at the functional level. If you map those national critical functions, the bottom of Maslow's needs, they didn't like that. So I said, okay, let's do latency sensitivity. How long can you shut it off before people die? If you start to map these, not only do you find that out of the 55 national critical functions, there's about a dozen that if you shut them off for 48 hours, people start to die. You lose the trust and safety of the public. You trend towards Lord of the Flies. But not only are they individually important, the chief most important of all, depending on your slice, is provide medical care. So if you shut off water, no hospital. You're gonna hear that several times today. We can go pretty far without electricity, we have generators, but you shut off water, lots of bad stuff happens. So what we noticed is any disruption in any of those dependencies can have a profound impact on provide medical care, and when we shut off medical care, we start to see excess deaths of 25 to 44-year-olds, including critical infrastructure workforce like water, wastewater, chemical engineers in Jackson, Mississippi, which when they didn't have talent, damaged their pipes and had a protracted long tail of effect. So this is a vicious positive feedback loop with negative consequences. Now, what the problem is here is we don't want to admire these problems. We know we have vulnerabilities. We know adversaries are taking advantage of these vulnerabilities, but we lack empathy historically to understand that none of this was funded. So I call them target rich in that adversaries like them, but resource poor or cyber poor. They can be cyber poor because they don't have the information, because we haven't given it to them, because they don't have the incentives, the carrots and sticks. Maybe they have plenty of money, but no one's encouraging them to do their job and protect the public. They care more about shareholders than stakeholders. And maybe in most cases, they're resource poor. And that this was, we added the connectivity without paying the price tag. So we want to have empathy for that, not just point it out. And what we did during the CISA work was try to be as scrappy as possible. And there'll be a single version of this in a moment. Okay. So one of the things I said is stop telling them to do best practices. They don't have any staff, they don't have any money. Let's at least tell them the bad practices. So we identified 3 of the most dangerous practices in critical infrastructure. And briefly, just so you don't wonder what I'm referring to, the use of end-of-life unsupported operating systems in the service of national critical function and critical infrastructure is dangerous. The overwhelming majority of our devices are on unsupported end-of-life operating systems. The end-of-life software should never lead to end-of-life for humans. Number 2 was the use of hard-coded, well-known default passwords is dangerous. Number 3 was the use of single-factor remote administration tools is dangerous. I just described almost everything on the edge of every hospital in America. So we at least want to draw a line that this should be considered the negligence line, and we should do our best as public-private partnership to fund getting people above that negligence line. That's not enough, though. So number 2, as I say, get your stuff off search, although I didn't want to say stuff. But the idea is your assets are showing, your adversaries can see them. So you should see what your adversaries can see. So which of your safety critical equipment is exposed to the internet? Can you remove the stuff you don't need to have exposed to the internet? Can you harden the things you do need to have exposed and fix the most egregious exploitable flaws? And then could you rinse and repeat on a regular basis? Really simple stuff, and yet way outside the reach of most of the nation's hospitals. We said, okay, if you can't fix everything once you find those things, just fix the ones that are being attacked. There's thousands and thousands and thousands of cyber flaws every year. But less than 3% ever get attacked, and even a smaller set is on this list called the KEV list, or known exploited vulnerabilities. So this isn't theoretical or academic, it has done harm to people in critical infrastructure. If it's on this list, fix it immediately. So we're trying to be like, what is the absolute minimum we have to do to stabilize and keep this patient alive? And it's avoid the bad practices, get your stuff off search, harden the things that have to be online for things like the known vulnerabilities. And then the White House really liked this, and you're gonna hear both from the White House and CISA, and they said, hey CISA, we like those bad practices, but what are some baby step good practices? If you can't do everything, what can you do as foundational? And they said, okay, we know that every sector is a beautiful, unique snowflake. That's true. But every snowflake has the same melting point. So can CISA, the nation's cyber risk management agency, look across the sector, not to say we're smarter than you, but they have the budget, the staff, and the mandate to do this. And if no one's doing this huge NIST cybersecurity framework thing, let's at least look at the handful of things everyone should do to start their program. And they came up with 38 foundational controls, like you cannot defend what you do not know you have, so can you at least have an inventory of your assets? Okay. We also had worked on SBOM, which is software bill of materials. We tend to use medical iconography, but the medical devices themselves, tend to have over 1,000 known vulnerabilities in them. They were unpatchable, they were pretty unsafe at any speed, and thanks to the courage of Suzanne Schwartz and the rest of the FDA team, over a 9-year journey, we did pass the Patch Act into law, which started last spring to be in effect, and this was mandatory minimum cyber hygiene for the medical devices created and sold into hospitals. And while I was very thrilled and proud to see this matriculation through positive effect before we had a lot more harm, it takes a long time to replace all your medical devices. And while this could benefit large, medium, small, rural, urban hospitals alike, that they're getting better, more defensible equipment, by default, whether they ask for it or not, you have to stay open long enough to actually get this. And you have to have a CapEx budget long enough to actually replace these. And we tend to see unhealthy levels of recall and end-of-life and end-of-support devices still in use in hospitals. So when you put all those things together, this pragmatic security suite was really just to stop the bleeding. When I'm trying to protect the vaccine supply chain, I didn't have 3 years to implement best practices or zero trust or hiccup or NIST cybersecurity framework. We had 3 months. So what could you do in 3 months? And we probably bought down more risk with this scrappy, pragmatic approach than hoping and wishing that people did the NIST cybersecurity framework for the last 11 to 12 years, where most people volunteered to ignore it. Doesn't mean it's better, it just means we have to meet people where they are and start to buy down risk. So the president said, let's take those ideas, the starting point, the CISA cross-sector cyber performance goals, and let's tell, in our presidential strategy, 5 different things, but 2 of them matter to critical infrastructure. Number 1 is we are losing the trust and safety of the public in things like water, food, urgent care. So we're gonna prioritize using the power of government. And number 3, was the incentives. So they said to all regulators, if you have regulatory authorities that are unused or underused, use them now. We have to maintain the trust and safety of the public. We're gonna use a light touch, but no lighter than necessary to do that. And they said start with the CISA cyber performance goals, the horizontal foundational things, those 38 things. And because you have unique sector-specific wisdom, add your sector-specific wisdom on top of that. So EPA should add different things, HHS should add different things, Department of Energy should add different things, and that was their mandate. So of those 16 sectors, everyone could do the blue, the NIST cybersecurity framework, 100+ things, but no one was. I said, let's all at least go to the basement and get rid of the bad practices across all these. They tasked CISA with coming up with homogenized cyber performance goals that everyone could do, and then they tasked the regulators to say, okay, use these CISA yellow ones and add your sector-specific orange ones. So we expected about 50 or so things required per sector, but they would not be identical. And then you might say, okay, well, what about all the supply chain and things like the FDA helped with to make medical devices safer? Well, those roots of the tree are the things sold into there, so we're trying to put much more onus on those who sell you critical infrastructure goods. So you have a fighting chance to begin with. This is the whole secure by design, secure by default push that you keep hearing about. And ultimately, maybe even liability. So liability is on the table from the White House strategy as well. So we want to make sure that if you're sold things that are safety critical, they are held at the same standard of care as other equipment you might buy, or ladders or cars. And what we're asking the hospitals to do, and CMS and HHS are making rulemaking now with Congress, and there's a lot of debate and fire over what's the right idea, is that we expect you to do your basic hygiene to make sure you're not doing the bad practices, you're doing some of those foundational things, and we're quibbling over what counts for those foundational things. Okay. So, but the bottom line is, whether we're talking healthcare here at CyberMed Summit, or the things that healthcare depends upon, like water, electricity, chemicals, we've been messing with the bottom of the pyramid. So it's a little hard to read here, but my general plea is that when everything's critical, nothing is. There's about 10 or 12 national critical functions where if we get it wrong, really bad things happen. These 10 to 12 are inherently cross-sector, so while it's important that we work with HHS, we also may have to work with EPA, with the Department of Energy, with other folks. This is an all-hazards thing, and Mark's gonna punch that home. But because this is such a cross-sector, cross-disciplinary set of challenges, it's critically necessary that CISA is both willing and able to do its job, and that its siblings in the federal government are willing and able to let them. And we still have a stalemate where most of these public-private partnerships don't want to deal with CISA. So we have some reluctance gap on both, and we're trying to encourage people to do the job that Congress gave them and that the public needs, and we're not there yet. So once again, I noticed the cavalry isn't coming. So people voluntarily can say, what are we willing and able to do to give them a helping hand, to give them the pressure to do the right thing, and maybe to help identify these cross-sector dependencies. So back to the provide medical care, let's do a tiny bit more. I hope I'm not going too fast. I'm watching. You're one of my markers. I'm watching. Remember those 55 things? There's 4 that healthcare is responsible for. 4 that the Healthcare and Public Health Partnership is responsible for. One is called protect sensitive information. Okay? PHI is the case here. If this is a different industry, it might be credit card numbers. Protect sensitive information. Before we had electronic records, nobody hacked healthcare. When we started aggregating them in electronic form, they were stealing in bulk. We started seeing people hack this. So you got the HIPAA rule and the HIPAA security rule 20 years ago. So the overwhelming center of gravity and thrust and original first principle that organized the way we do cybersecurity is the confidentiality of data. We protect patient data. It's how we talk, it's how Congress creators still talk. But there's 3 others that over time started to manifest harm. The second one is called maintain access to medical records. Specifically, what we mean is EHR, EMR workflow. So I just said we want to make confidential the data, which is you shut it off, you hide it, you encrypt it. But we also need to do diametrically the opposite thing, which is maintain access to it. Because when access goes away, you can't do workflow, you can't have cash flow, you have delayed, degraded patient care, which worsens outcomes and loss of life. So when we started seeing Hollywood Presbyterian Hospital in LA get hacked in 2016 by accident, we saw they had to divert ambulances, cancel surgeries, move critical care patients. It was harrowing, very risky for a single one, even worse if all the LA hospitals got hit. And since then, ransomware has targeted hospitals as the #1 victim across all 16 critical infrastructure sectors, with year-over-year growth that's staggering. What went from a handful, the FBI tracks every one of the 16 sectors. Healthcare and public health has the most attacks yet again in their last annual report. They tracked, I think, 249. Our private information sharing groups crossed the 700 mark in August last year. So they're probably undercounting significantly based on what we actually know. So maintain access to medical records is also a responsibility for the healthcare and public health sector. Provide medical care is the most important one. Can you get timely access to care when you need it and where you need it? And increasingly, the unavailability of the EMRs and the equipment in the hospital affects this dramatically, and people die. And then third is a little fuzzier. It's not a hospital at a time, but it's called support community health. And under this banner, a region wouldn't care if GW medical went down as long as there was enough public health capacity and public health planning to absorb that overflow. But increasingly, as these hospitals suffer protracted cash flow disruption from their multi-week, multi-month event, they are closing their doors forever, or weakened enough to be the part of a predatory acquisition and weakened further. So it is also undermining our ability to support community health. So while we have 4 national critical functions, the overwhelming majority of our best practices were designed in the era of keeping things private. The next time you hear a breach on the record, on the news, or you hear an interview, they will say, in an abundance of caution and in accordance with industry's best practices, we have chose to contain the breach and shut things down. And by virtue of shutting things down, they just harmed the last 3. So the ransom might have gotten you a fine and be on the wall of shame, but shutting down operations or allowing them to be shut down kills your cash flow, kills your patient care timely delivery of care, and eventually can kill your hospital. So qualitatively, not to scale, the NIST cybersecurity framework was voluntary 12 years ago. Because no one was doing it, the White House asked CISA, that middle column, to come up with a 38 foundational, the crawl stage of crawl, walk, run. So the presidential intent was to say, CISA, come up with these, and then ask each sector to add to those green. And I think with the best of intention, having empathy for the fact that we have target-rich cyber-poor hospitals, HHS and the sector leadership kind of said, well, we can't afford anything, something's better than nothing, we're gonna make 10 of those 38, call them the HPH sector-specific goals. They're essentials, and the 10 extra ones are bonus ones called enhanced. So if 11 years after we said what best practices were in blue, we said maybe let's just start with something easier like 38, and instead we're gonna get 10. And this is the debate we're having now, and I'm in the camp that that is not enough to stop the closures of hospitals and the harms to patients. And it's uncomfortable because that's what we can afford. So my left hand is what do we need to stop hospitals closing and keep all 4 of those national critical functions resilient to protect the safety, trust and safety of the public. And in my right hand is what we want, what we can afford, what we can implement quickly. And the larger the gap gets between what we need and what we want, the more harm we're gonna see. Now, what do I mean by that? I'm turning the corner here in the last few minutes. I did my animation too quickly. You will often hear sincere but false beliefs of, this is what we need to do because this is how we're getting beat. If you had a park with no fence anywhere and they tend to be using this walkway, what we're effectively doing is we're putting a gate on the walkway. We have a number of ways people can get into the hospital. They're going to get into the hospital. They might even ransom you. They might even steal things. They will get in. I want to limit how much damage they can do to patient care, to patient resilience, to cash flow. So we're humbled again because while we've been debating what do we do and celebrating the FDA Patch Act, we thought we could just add some minimum cyber hygiene from the president's plan. It got watered down a lot by HHS in the sector, but in parallel, St. Margaret's in Illinois, a nonprofit, closed its doors forever. It's one of the many hundred of hospitals across the US footprint who have closed their doors forever, and that community is now underserved or has a much longer commute to get urgent care. They are not the first one to close, but they are the first one to publicly admit that their ransom event was a contributing cause of their death. Because if you have 4 to 6 weeks of cash on hand, and a ransom lasts 6 to 12 weeks on average, you're probably gonna go out of business or get acquired. And this has happened 250 times a year, according to the FBI, and more like 750 times a year, according to open source intelligence. So one of the things I want you to wrestle with your cognitive dissonance, because everyone has a truth when they come in this room, but we have to have a greater truth. We have to combine these truths. So philosophy 1 is President Biden's strategy. We want you to start with the CISA cyber performance goals and add your sector-specific wisdom. So 38 plus a dozen things, like EMR, EHR wisdom. We have the HHS plan of record from December, which was done in good faith and tried to ground itself in our constraints and our budgets. And that one is 10 of those 38 of those 100 plus NIST things. And these are both checklists, so even though I respect the president and I respect HHS, I'm gonna offer a third today, briefly. What if we don't do either one of those yet? What if we stabilize the patient, keep hospitals open and alive? What if we treat this more like a battlefield tourniquet? Or maybe we can do all the above. But let me give a fresh second opinion. So first, let's do another close your eyes thing. I'm gonna go 5 minutes long, but close your eyes, I mean it. I want you to picture your hospital. Picture the name of your hospital. Answer the question for yourself. When was the last time I went to that hospital? Was it to welcome a new baby into the world? Was it to say goodbye to a friend? Did a loved one get hurt and need to wait for an emergency room? How far away was that from your house? Was it 5 minutes, 20 minutes, 45 minutes? Right. Now I want you to picture that you need to go to the hospital. That hospital is no longer available to you. Where would you go instead? Is it across town? Like here in DW, you might have a pretty close by alternative. Is it in the town next to you? East, west, north, south? Is it the county next to you? Would you get there in time for every condition you might need treatment for? And the last question before you open your eyes, is it owned by the same company that owns your hospital? Or is it under negotiation to maybe be acquired? Because what happens if it's also down from these increasingly larger cascading failures where you don't just hack one hospital, it's a 22 state shutdown like Common Spirit. All right, let's open our eyes. how many times we see a closure, an elimination of, this is from, this is an animated map of rural hospital closures, not acquisitions. They're gone. If you see a dot, put a little radius around that dot. If it's more than 4.4 minutes, that community is going to have worsened heart outcomes. If it's more than an hour, it's going to have worsened stroke outcomes. And in some cases, it's 4 or 5 hours. So every time you lose a dot, when Mark and I did the Congressional Task Force for Healthcare, we had 7,000 hospitals was our number. Now when you hear the government talk, we have 6,000 hospitals. They are not all due to cyber, but cyber is making it worse. It's accelerating the closure, permanent closure. So the only thing worse than being down for 6 weeks is being down for good. So my assertion to you is if we just do what we want to do or what we think we can afford to do, or we say something's better than nothing, between now and 2029, if the last 5 years cost us 200 plus rural closures, we should expect to see another 200 plus more. And at what point are we allowing entire communities to have degraded delayed care, denied care? So I'm getting serious because things have gotten serious. And we have a window of opportunity with the White House, with bipartisan House and Senate, with the executive branch, to maybe measure twice, cut once, and give not just aspirin for your cancer, but a sufficient, fit-for-purpose dose to cure the patient. So to me, the success here isn't you do a checklist. Which checklist is it? Our performance objectives should be, can we prevent more closures of small, medium, rural, and urban healthcare, which is 85% of the national footprint? And can we stop thinking about what we want, instead focus on what we need? And then the last, turning in the corner, every one of those debates we talked about between the president's strategy, the HHS sector strategy, and maybe a resilience kind of a strategy, every single one of them predates Change Healthcare. So even if every hospital did everything perfectly, our mutual dependence on a ball bearing known as Change Healthcare means that a single compromise drained the cash on hand reserve for almost every single US hospital and pharmacy, several of which are closing and or being acquired. So this disruption reminds us of the overdue need to do all of these strategies ignored. Those. We're focused on medical devices and Patch Act, we're focused on hospitals, checklists for these three. So SICKI is something I hope you're going to hear from Kirsten Todd and the system people and the White House people. It's systemically important critical infrastructure or systemically important entity. No one wants to make these lists, but there's about a dozen or so entities in any given sector that have an outsized impact. You know what's missing from the healthcare and public health sector? Cyber-specific, cyber performance goals? EMR systems. What's the central nervous system of a hospital? EMR systems. So we have to look at which vendors, entities, or functions, if disrupted, have an outsized role on adverse events for those 4 critical functions. And then the last one you're going to hear about from some of the national security people, I hope from Mark, there's unclassified briefings from all 4 of our top leaders for cybersecurity in the US called Bolt Typhoon, and it's just one campaign from China. China is going to take Taiwan as early as 2027, plus or minus 2, and they were caught, quote, pre-positioning. They had hacked many US water facilities, not to do a ransom, not to cause panic right now, but in case they want to have it as a deterrent so the US stays out of their conflict in the South China Sea, and or if we do get involved, to disrupt and rain chaos on US critical infrastructure like water. So even if they're not targeting hospitals with a campaign like Bolt Typhoon, no water, no hospital. And the triviality with which US water can be hacked is the last hack from the cyber vendors in Iran used a hard-coded password of 1111. So hacking not really required. So whether it's the Change Healthcare disruption, which no one saw coming, or the Bolt Typhoon disruptions, which is coming, let's give HHS and the sector leadership some grace and say, okay, you had your list, we've been debating your list, we now know Change is bigger, Ascension's bigger, and Bolt Typhoon could be much bigger in a 2.5-year time frame. We're going to need a bigger boat. So I'm going to challenge each of you today to listen critically, not to what you want or what you were fighting for, but maybe what we need. I don't think it's going to be a checklist, but they'll be in the mix. And my last 60 seconds I think I can do is I'm going to articulate my steel reinforced cockpit door. Let's say it 2 minutes. One, after 9/11, we saw that hijackers could get on commercial aircraft and turn them into missiles. Did we throw away all of our aircraft? We did a lot of stupid things in the country. We violated civil liberties, we went to wars. We're still not fully recovered from the stupid things we did, but one of the smartest things we did is we realized hijackers will get on the plane. Let's make sure they can't get in the cockpit. So we add steel reinforced cockpit doors. So my simple, oversimplified thumbnail for today, just to provoke thought. What are the steel reinforced cockpit doors in hospitals? Maybe we don't have to secure everything from everyone, from every way we get beat. What are the time-sensitive services like heart, brain, pulmonary, that are too time-sensitive to fail, and let's harden just them, such that we can have a successfully ransomed hospital for the next 10 to 15 years, but that ransom does not compromise the timely delivery of patient care. It does not kill the cash flow to close hospitals. So number one is, what are the hardened services that we should direct our surgical fire towards? Number two, within those critical care chains of, excuse me, this is number two. Within those critical care chains, which, let's just inventory and harden those services and direct our regulatory pressure towards a fraction of the hospital while we stabilize the patient. Second thing is, let's get rid of the most dangerous devices in the direct pathway of critical care. So maybe a Windows station for business office is not important, but a Windows station in the critical access of stroke intervention is important. So let's replace with cash for clunkers the unsupported end of life, dangerous devices, recall devices in the direct critical path of that service. Number three, let's take a regional approach. If there's sufficient regional excess capacity, that's a less risky region than one that has one and only one hospital for a 3-hour radius. So let's give an outsized level of assistance and scrutiny to the hospitals that lack proximal alternative care. And number four, if we're gonna have stuff on fire for the next 10 to 15 years, we need better and more well-staffed fire trucks or emergency response. And you might think I'm gonna say more CISA, more FEMA, more ASPR from HHS, which is on the list, but it actually needs emergency funding. Maybe surge nursing, maybe surge equipment for time-sensitive things like stroke in a box or urgent care for heart. So let's understand the reality we face is going to be elevated levels of fire. Let's make sure the fires are 7 to 10 days, not 7 to 10 weeks. And then lastly, as we're seeing with the Security Exchange Commission or the response to Enron with Sarbanes-Oxley, if this isn't a board level concern and a CEO level accountability, nothing's going to change. So let's talk about those checklists and compliance, and is it the president's CPGs or the HHS CPGs? Let's do those. Let's add the carrots and sticks. But it has to be an executive accountability, because I don't want to depend on the heroism of hackers, the heroism of nurses, the heroism of ISACs. I want to make sure we place the accountability where it belongs. There is a cost to connected medicine. We have not sized or paid that cost, and instead we're paying different ways. So I said a lot of things, but we have a couple different competing philosophies you're going to hear today. I hope you can see the urgency, because this is messing with the water you drink, the food you put on your table, the electrical power, timely access to patient care, and I don't want to come here 2 years from now and say that we lost another 200 hospitals, and neither should you. So, if you're a humble seeker, if you're open-minded, if you're going to be a systems thinker, if you're going to be a boundary strainer, if you're going to say, we need to be better, thank you for coming today. Bring the urgency and courage. We are over-dependent on those undependable things, and at least for now, you are the cavalry. Thank you. Let's take a break.